In this lecture, we will focus on the diagnosis of arrhythmias on the ECG rhythm strip. This is not intended to allow you to diagnose every single cardiac rhythm that you come across, but will cover the main arrhythmias you are likely to encounter and give you a systematic approach in diagnosing them. By the end of this lecture, you will be able to recognize the cardiac arrest rhythms, have a basic understanding of the cardiac conducting system as we have already discussed in our first lecture, and recognize other important rhythms that you might come across using a structured approach to ECG rhythm assessment. So, just to remind us, the cardiac conducting system is a system of fast conducting cells and pathways within the heart that allow electrical activity to flow through the heart in a structured manner to provide a coordinated set of contractions of the heart, first the atria and then the ventricles. The rhythm starts in the SA node and that produces and propagates throughout the atria, which produces your P wave. There's then a pause between the atria and the ventricles as the conduction passes through the AV node, and this produces your PRR interval. Then conduction passes across the septum, down the septum to the apex, and then up the sides of the heart. That produces your QRS complex. Repolarization of the cardiac muscle in the ventricles produces your T wave. So let's think about a few cardiac arrest rhythms. A 38-year-old woman is brought to the hospital after having collapsed. The ECG shows the rhythm at the point of collapse. So the question here is, what is the rhythm? But of course, the first thing I want to ask is, what are you going to do about this patient? And your real answer should be, you will assess the patient. If you find that the patient was without pulse and has no signs of life, and you see this rhythm, you should be thinking about asystole. Of course, you're going to do your checks to make sure this isn't due to a loose lead or being on the wrong lead or not having gain up in the machine enough. Let's look at another one. A 50-year-old man collapses suddenly while sweeping out his drain. What is his rhythm? Again, think about the patient. If this is a patient who is in cardiac arrest, this kind of disorganized rhythm would fit with ventricular fibrillation. It's probably the most important rhythm to recognize in the cardiac arrest patient, as it is the most treatable and responds to defibrillation. Here's a 65-year-old man who collapses suddenly after suffering 15 minutes of severe chest pain. So if you look at this rhythm, and we'll come to it again, it's a broad complex tachycardia, you may say this is a ventricular tachycardia, and you would be right. Of course, when asked how it should be treated, your first question should be, how is the patient? If this patient has no pulse and has no signs of life, then this is pulseless ventricular tachycardia and is treated the same way as ventricular fibrillation. Finally, a 35-year-old asthmatic with severe bronchospasm. At this point, he is not breathing and has no pulse. This, although it looks bizarre, is a rhythm in which you would expect a pulse. This patient has no pulse. That is the definition of pulseless electrical activity. The reason we started with these 4 cases is because these 4 cases are cardiac arrest cases, rhythms. You need to recognize them quickly, start CPR, and decide whether the patient needs defibrillation. So here's another guy. He definitely has a pulse. He's come in for a pre-employment checkup, and that's his ECG below there. How do we decide on this patient's rhythm? I think all of us can look at this and say, okay, it's sinus rhythm, but how do we break this down even more? So we're going to use this approach. 6 questions. How is the patient? What is the ventricular rate? What's the rhythm? Are there P waves? How are the P waves and QRS related? And that has two parts. Is there a P before each QRS? And then what is the PR interval? And finally, what is the QRS duration? Which is to say, is this a narrow complex or a broad complex rhythm? So if we apply this, we'll apply this to the cases, subsequent cases. 21-year-old athlete coming for his yearly checkup. So, first thing, if we look at his rate, we can count 1, 2, 3, 4, 5 and a bit. Say 5.5 large squares between QRS complexes. That correlates with a rate of 300 over 5 is 60. So just a little less than 60 beats per minute. Is this regular or irregular? Well, if we look at the spaces between the QRS complexes, we can say this is quite regular. Are there P waves? Yes. And what about the P's and QRS as well? There's a P before every QRS, and the PR interval is constant, and it's 4 small squares. It's less than 5 small squares, so that's normal. 3 to 5 small squares is normal. So we can say this is a sinus bradycardia, probably due to his athletic physique. Here's a patient with a fever. Again, the rate is 300 over 2.5, which is about 120. It looks regular. The QRS complexes are regular. There's a P before every QRS, and the PR interval is about 4 small squares, so again, normal. This is sinus again, but it's fast. Sinus tachycardia. How do you treat a sinus tachycardia? Really, you treat the underlying cause. So it's a bit different. This is a patient with palpitations, an elderly patient with palpitations. So what's the rate? Well, there is a variable rate. When you look at some squares, less than about 2 big squares between the QRSs, that's about 150, and then some have 4, that's 75. So it varies between 75 and 150 beats per minute. And that is because if you look at the distribution of the QRS complexes, they are irregular. Are there P waves? Where there's a jagged line underneath, but no discernible P waves. So this is a fibrillation pattern, and the combination of this chaotic baseline with irregular QRS complexes tell us that this is atrial fibrillation. The activity in the atria is disorganized, and beats are getting through to the ventricles in a disorganized fashion. So you have the fibrillating baseline and the irregular QRS complexes. Atrial fibrillation. Here's a man whose experiences in heart racing. If you look at the ECG, the baseline has a very distinct pattern called a sawtooth pattern. The QRS complexes are regular at 100 beats per minute. That sawtooth pattern tells us this is likely to be ventricular flutter. Ventricular flutter is an organized but very fast rhythm in the atria, and there is some degree of AV block so that not all the complexes get through to the ventricles, and therefore the ventricular rate will be some fraction of 300. In this case, the block is 1 to 3, and the rate of the ventricle or the QRSs is 100 beats per minute. So this is atrial flutter. The rate can vary between 75 and usually 150 beats per minute, but it is really some fraction of 300. Here's a 20-year-old female who presents with sudden palpitations and shortness of breath. So this is a tachycardia. The rate is more than 150 beats per minute, closer to 180, because it's number of large squares 300 divided by the number of large squares, or alternatively 1500 divided by the number of small squares between QRS complexes. It looks regular. When you look for P waves, you can't see any, so we can't talk about the PR interval. But the QRS complexes are narrow. This is a regular, narrow complex tachycardia with no discernible P waves. That pattern fits with supraventricular tachycardia, what we commonly call paroxysmal supraventricular tachycardia. Often responds to vagal maneuvers, carotid massage, or adenosine. What about this one? We saw this ECG before. The rate is 150 beats per minute, about two large spaces between beats. There are no discernible P waves, so we can't talk about the PR interval. It is regular, and the QRS complexes are obviously broad. Anything over 2.5 small squares represents a broad QRS complex, but this is obviously broad. In this setting, we would consider this to be ventricular tachycardia. The treatment depends on whether the patient is stable or unstable. We deal with that elsewhere. Here's a 56-year-old hypertensive with a history of angina. Now we're looking at slow rhythms. So the rate here is 1, 2, 3, 4, 5, 6, 7, 8. 300 divided by 8 is about 37 beats per minute. There are P waves, and there is a P before each QRS. However, the PR interval is prolonged. It's 1, 2, 3, 4, 5, 6, 7, 8 small squares. It shouldn't be more than 5 small squares. Beginning of the P wave to the beginning of the QRS complex. But every PR interval is the same, and there are no drop beats. So this is what defines first degree heart block. No drop beats, but a prolonged PR interval. Here's another patient with severe chest pain. And if you look at this, first thing, without going into details, you just eyeball this and you can see missed beats in between. This is a rhythm with dropped beats. Drop beats usually represent some kind of second degree heart block. Let's look at the P waves. There are P waves, but not every P wave produces a QRS complex. Now, let me just do something here. Let me just get my pointer. Now, if you look at this PR, this one is a bit longer, this one is a bit longer, and then we have a P wave with no QRS. So this is drop beats, but there's progressive prolongation of the PR interval until a beat is dropped. That defines second degree heart block, Mobitz type 1 or Wenckebach. Here's Mobitz type 2. Clearly there are drop beats. There's a PR interval here, here, and here, and they are all fixed. However, we then drop a beat and another beat. And that defines Mobitz type 2 second degree heart block. Drop beats, but where there is a PR interval, it's constant until a beat is dropped. And of course, finally, we have a patient here with broad complexes and bradycardia, but there are no drop beats. These complexes are evenly spaced. Then we look at the P waves, and the P waves are evenly spaced. However, there is no fixed pattern in the PR interval, and that's because the P waves are going along at one rate, the QRSs are going along at a different rate, and they're not speaking to each other at all. This is third degree or complete heart block. So that ends this talk on cardiac arrhythmias. This is an introduction to how you might apply a systematic approach to diagnosing arrhythmias. It will serve you well for most cases, but some cases may need further analysis.